Good evening. This is the second actually, of our events for under the name of APIS Health Angels that we're running. The purpose of the education sessions are to get people to be ready, understanding what it takes to invest in healthcare, to move startups along, to be stronger and ready to take an investment, and for investors to be able to understand what it is to that startups have to face as they're developing their new products, and what it takes to bring them to market. So we also are hoping that investors will be able to decide what makes a good company and what makes a good investment. And as you're going along, you'll be developing your investment thesis about what kind of companies that you're most interested in. One of the things that we know that as we're doing this is that return on investment is an important thing for all companies to be able to showcase. And that's the focus of our talk to this evening. All right, Craig. Craig and I met about 8 months ago when he was actually giving a talk on Joe Hage's Medical Devices Group calls, which are often on Friday mornings from 8 until 9. And Craig actually gave a very interesting talk that resonated with me because my husband has done a lot of work on health economics, and I have spent a lot of time trying to justify new treatments, both as an administrator in the hospital, but also in a consulting practice. And this, I think it's going to be a great opportunity for you to talk about how do we say this is something of value. And I'll turn it to you, Craig. You can introduce yourself a little bit more. Craig is a published author, and the cover that the Eventbrite was his book. It's available on
Amazon or from Springer directly. So
yeah, I got it from Springer. So maybe another route is Amazon, and we'll put your link. I'll put the Amazon link in the chat box as we go. So Craig's going to talk for a little bit. He is interested in hearing your questions as you go. So if you have things that you'd like to raise, then you can put them in the chat box, and either Craig will look at them as he's going along, or I'll address them so that he can step forward on this. And we'll let you take it away. Thanks, Craig.
Great. Thank you so much for having me. I'm excited to be here. My name is Craig Solid. I'm going to put up some slides here.
You should be able to do that. Yeah.
There we go. So I'm going to talk to you about ROI, but also value assessments in general. And I combine them because when I talk to groups, sometimes they want to talk about ROI, sometimes they want to talk about value more specifically, but sometimes when they say ROI, they actually mean value. When they say value, they actually mean ROI. And they're so closely linked that I can't find myself talking about one without talking about the other. I am an independent consultant, as Elizabeth said. My background is actually, I'm trained as a statistician and health economist. So I spent many years as a health services researcher doing claims-based analyses for medical research. These days, I mostly help organizations demonstrate the value of their product, device, process, service, or solution. They might be trying to demonstrate it to a payer, to an investor, to an end user like a physician or a health system, or to a company that they want to be acquired by. So there's quite a variety in that space. And as Elizabeth said, my book is there. I wrote it for non-analytic people, so those who don't have a strong background in analysis or statistics or economics. It's intended to just have some practical suggestions for here are the things to think about when you're trying to do this. So I know we have a sort of a variety of some people who work in medtech and some people who are investors and some people who are both. So this is a good mix, I think, for what we're going to do. So to start, I always zoom out and start and talk more generally about value. You know, as I think it was Deborah mentioned, value-based care these days is a huge industry. And when we talk about value, unfortunately, we throw that word around a lot, but we don't necessarily have a shared vernacular of what we're even talking about. You know, the most common definition that I think that we have in the healthcare industry is the one in front of us, which is typically attributed to Mr. Porter, who wrote about it in the New England Journal a little over a decade ago. Simply that value equals quality divided by cost, or quality per dollar spent, and things like that. And that's fine. There are situations where you can look at that equation and say, sure, if we can hold cost constant and increase quality, there's value there, right? But it really loses a lot of the nuance of value, and it uses one subjective concept, quality, to define another one. So I think it very much is lacking in terms of a definition that we need as an industry if we're going to actually you know, tie reimbursement to value and how we think about it. So when I think about value, I always ask groups, you know, to think about it, and I say, well, it depends on a lot of things. First and foremost, it depends on the perspective. So you can't really talk about value until you say value to whom, right? The same device, the same change, the same intervention is going to have different amounts and different types of value for patients than it would for providers or payers or administrators or society, right? And until you get clear on who you're talking about in terms of that value, it's hard to really define what value is. It also is going to depend on the situation, what your motivation is, what decision you are trying to inform. Sometimes we're trying to inform a clinical decision and just simply are interested in clinical benefits. Other times we're interested in patient well-being and quality of life. Sometimes we're trying to decide whether or not to invest in a particular solution or intervention. Other times we're trying to decide between options. And so the given situation will very much influence how we think about value. It's also going to be a function of what you can actually measure. Those in the healthcare space know that when we have been trying to measure quality for these last few decades, the definition of quality depends largely on what's measurable. What data are available? How can we get them? How good are they? You know, value and quality as concepts are subjective, and there's not necessarily any way to measure them in their entirety. We use surrogates like rehospitalization or infection rate or mortality. And when we use these surrogates, how good they are really impacts what we can measure and how well we can measure it. The comparison also matters. You know, the most common question I get in ROI is, well, what's a good ROI? What should I be looking for? And the answer is it really depends. I mean, when we're talking about a financial return, you know, depending on the perspective and the situation, you can imagine that it might be okay to have an ROI of 0, right? If you break even and yet you are able to produce all sorts of non-monetary value or benefit, that might be perfectly acceptable. You might even be able to imagine scenarios where a negative financial return is okay. So the comparison is really going to influence what we determine about value as well. And then finally, the stakeholders or the audience, you know, depending on if you're talking to a payer or if you're talking to a policymaker or you're talking to a patient, how you are going to talk about value is going to differ. A lot of times we choose our audience is the same as the perspective, right? If we're trying to convince a provider that this new device is going to have value for them, we're going to take their perspective when we talk about value and aggregate value and quantify value. But it's not always going to be the same. Sometimes we might be talking to policymakers or payers and want to take the perspective of a patient. But all these things sort of factor into value, and you can see that you can look at the same thing and it can result in very different definitions. So an example I like to use is reducing falls. It's a very tangible example. So in a situation where we might have a goal to reduce the frequency or severity of falls in a facility, the perspective from which we are going to look at value is going to define value very differently. Patients the value that they get from reductions in falls is going to be different than the value that payers get, right? Payers are going to be interested in lower costs, less utilization, things like that. Whereas patients, it's about peace of mind and confidence and quality of life. And for the facility, they have yet different measures of value. Similarly, how you define it is going to be a function of what's measurable. Yes, you can measure all falls. Yes, you can measure which falls result in injury. Can you measure the fear of falling or increase confidence? Maybe, depends on the situation. Physical activity, things like that. You can imagine there's all sorts of things that might be benefits from reducing falls, only some of which you will actually be able to measure. So I think it's a problem right now in our industry. There was a recent systematic review that looked at, I believe it was 38 articles on quality improvement initiatives, and it reviewed the different methods that were used to assess value. And they said that they identified 22 distinct approaches to assess value. And that the most common method, which happened to be cost effectiveness, was, quote, not sufficient to meet the needs of decision makers. So when I read that, I think that's a problem. It's a fundamental breakdown in how we think about value. Either we're not thinking of it correctly, or the tools that we have are not sufficient to answer the kind of the questions that we are trying to ask. And so this is why I think it's not about defining value this way, or this is the method to use. I think what we need to do is teach people how to think about value so that they can develop their own definitions and their own methodologies that will be appropriate and applicable for individual situations. So there's a lot of reasons why this is. I mean, we haven't just dropped the ball as an industry. It's a difficult thing to do. The healthcare industry is complex. There's often a lack of continuity and also a lack of consistency. So, complexity, there's the way that care is even delivered is complex. You go into an emergency department, the myriad of people and services and the environment and technology, how they interact with each other is a complex system and won't always produce the same results, even if the same inputs are there. Patient health is complex. We know that it's a connection between mind and body, different organ systems. It's not just, hey, let's treat this one ailment and everything will be fine. And then obviously how we pay for healthcare is extremely complex. And if we're talking about value, that has some serious implications for our ability to assess value. When it comes to continuity, we have been shifting towards more of a care continuum, trying to get less episodic care. And at the same time, we have sort of changing policy in terms of how care is paid for. And the consistency I mentioned before, we have inconsistent definitions and inconsistent motivations for what value is and why we are looking at value. And I think these things together make it hard to accurately measure value. It makes it hard to attribute value to a particular activity or department or system. It makes it difficult to isolate the different components to know what is affecting the result, and it makes it really hard to make comparisons. So all these things together make it very difficult to talk about value. So like I said, I don't think there's a single definition. I think it depends on all these things we talked about, and what we need to do is think about, how do we want our industry to talk about it and think about it, and sort of what kind of framework do we want to have to develop it. So there's a couple examples I'd like to give groups just as sort of thought experiments or thought processes as you think about value. So the first one, if we were to say, there's a treatment that reduces depression and anxiety, and it's been shown to reduce work absenteeism and increase productivity. If we're going to assess the value of that, initially we might say, okay, well, part of the value comes from the increase in productivity, GDP or whatever kind of measurement of productivity that we want. Well, as soon as we do that, we have to acknowledge that, well, if we do that, then maybe that means that treatment is going to be more valuable when given to a cohort of working age adults than when given to retirees. And so here's an example of, well, when we define it one way, that has implications for how we're going to interpret it later. And so I think we have to be careful about how we do it. I also like the example that I'm going to show you in a second of what some authors call a hopeful gamble. What they did is they talked to a group of cancer patients and they asked them to consider two hypothetical treatments. The first treatment would be guaranteed to provide them 18 additional months of survival beyond what they were already doing. The alternative would be basically a gamble. With 50% probability, it would give them 36 additional months, and with 50% probability, it would give them no benefit, 0 additional months. Now, mathematically, these are identical. The average sort of additional benefit of these of each of these is 18 months. But the authors found that 77% of the surveyed cancer patients preferred the hopeful gamble. So they said, what does that mean? And basically what they determine, as their title suggests, that there's a value in simply hope. Patients can place hope on the potential for long-term survival above and beyond its contribution to average survival. So to me, these are just examples of we need to think about value sort of more broadly than maybe we have before. And in every situation, there might be a unique way to define it, and we need to get past simply, quality divided by cost. When I talk to startups and I talk to device companies and I talk to those seeking funding or whatever, one of the things that I talk to them frequently about is framing the value as an opportunity. So what do I mean by that? Well, I mean, instead of launching into here's our solution, here's our device, start with where's the gap in care? What's not as good as it could be right now? Right? How many patients suffer from this condition? Where are they lacking? And how much does that cost particular stakeholders? And then once that's out there, then you can talk about what portion of that gap does your solution address, and what are the practical considerations that you need to sort of understand if you're going to demonstrate that in terms of, can we measure the impact? Is it feasible? Will patients use it? Will providers use it? So there's sort of a combination of the kind of technical and practical consideration. So as an example, I worked with a medical device company that had a device intended to improve medication adherence for community dwelling adults. And one of the things that they sort of struggled with was getting clear about who their target population was. Initially, they said, hey, anybody who is living at home would want this device. And they got a lot of pushback. A lot of people said, not everyone who's living by themselves or living at home wants a video, medication monitor in their home. They're not okay with that. Not all of them will use it. It won't help all of them. So we had to get clear about specifically who it was for and in what situation and circumstances. So what we did is we picked one specific gap in care as a very tangible way to illustrate it. We said, let's consider a common ailment that involves medication, specifically hypertension. So what do we know about hypertension, and how can we demonstrate a gap in care when we go talk to payers? Well, we know from published literature that once you get to a certain age, your likelihood of having hypertension is anywhere from 40 to 60% or higher. Most of those people have it diagnosed. Most of them have been prescribed medications, but as many as half of those still have high blood pressure. And as many as 80% of those have uncontrolled blood pressure because of poor adherence. Now, the reasons for poor adherence might be varied. It might be they have a complex medication regimen. It might be that they have some level of cognitive impairment. It might be that they intentionally aren't taking certain medications because they just don't think it's helping them. Whatever it might, they might be forgetful, whatever it might be. But in part of the gap in care, this is a significant number of people. And what are the implications? These people who simply are not able to take their meds as they are prescribed are at a higher risk of heart attack, stroke, heart failure. So when they go to talk to a payer, this device company says, okay, let's put some of these numbers into tangible terms and say for every 1,000 members, this might mean 25 additional heart attacks each year at $20,000 per event. That's $500,000. 15 additional strokes is going to be this, et cetera. it might be $1.2 million per 1,000 members, simply because a certain group of hypertensives are not able to take their medication as prescribed. Now, this is just the opportunity. They haven't talked about their device at all yet, right? They're just sort of framing the value in terms of what is the opportunity, what could we possibly capture. Then when we talk about the impact of the device, then they can go on and say, well, what part of that could we capture? Say we were able to improve adherence for, say, 60% of these folks. That would reduce the risk of adverse events, and potentially for the 1,000 members might help you avoid 15 heart attacks, 10 strokes, etc., and potentially capture $600,000 of the full opportunity, right? So in this way, they're talking about value, but they're doing it in such a way to sort of framing the problem and then identifying the solution. There are times, there are device companies that I've seen, med tech companies I've seen, that have a solution without necessarily a problem, right? They are sort of searching for a problem to apply their solution to. So if you can frame out the solution right away, then that means that it is potentially of interest to a payer or someone else. Now, the 60%, all these numbers are sort of, they're sort of based on literature, but they're kind of made up. And when I say, 60%, why can't we improve adherence for everybody? Again, you need to take into account practical considerations. This device isn't going to help people who are just not taking their meds because they don't want to, or it's not going to help people with cognitive impairment or whatever. So, there's practical considerations that go into the impact of this as well. But that's how this company decided to sort of frame it. So a second scenario, I worked with a urology service that improves symptom tracking. So in urology, certain conditions, a lot of times there are diaries that are supposed to be kept by patients. And a lot of times those are just handwritten diaries and may not be super accurate. A lot of times in urology too, a certain number of patients just stop coming to appointments, or they get their sort of first therapy and it helps a little bit and they're a little embarrassed by the situation. So they're just like, this is fine, I'm not going to come back. So this service did something similar. They talked about the gap in care, but they were interested in being acquired. So the other thing that they did when they talked to the acquiring organization was to say, hey, our service has also shown that people are more likely to come back for subsequent lines of therapy. So we can actually increase the patient population that urologists will actually see in addition to helping patients with the condition, right? So progressing through more lines of therapy, patient retention, these are sort of more of the business case for an acquiring organization or providers to say, in addition to lower utilization or better care, there is greater market capture, right? Maybe it's going to be a complementary device to something that acquiring organization already has or something like that. So when we think about the opportunity, there's a couple ways to think about it, and those are just some examples. So one of the things I share with clients is sort of a short checklist and say, if you're trying to figure out whether to do this, start with, can we size the opportunity? What's true about the issue your solution targets? Bigger opportunities are going to be ones that deal with more common events or conditions that are more costly to treat or require more frequent care, ones that are extremely important to patients and families, the current solutions fail to fully address the issues, et cetera. And then you can sort of quantify what's the magnitude of the impact in terms of adverse events or patient outcomes, efficiency, and then of course there are practical considerations. So it's a very simple checklist, but it gets these organizations to sort of think about, what are we doing and how are we going to think about this so that we can do it in the best possible way. Let me pause and just look at some of the comments that I know have popped up here. So yeah, savings in the form of money not spent later. So cost avoidance, Yep, patient acquisition and retention, greater market capture. Exactly. So where does ROI fit in? We've been talking about value more generally. So ROI is a piece of the puzzle, right? But it's not the full piece. And what I tell people is that even if you're talking to payers or people like that, or groups that you might think are only interested in the financial return, often, more than often, almost always, they are interested in the larger context of value. They're interested in caregiver burden. They're interested in quality of life. They're interested in patient experience. Perhaps some of that is because they know that that's about member retention, for example, and things like that. But they are interested in, they know that the things that have staying power are the things that provide value in more than just a financial return to payers and providers. So it's important to sort of put it in the proper context. So if I were to define a value assessment as simply, broadly, the consideration or evaluation of benefits from one or more perspectives in light of or relative to costs needed to achieve those benefits within a particular time period and for a specific group of patients, ROI is a lot simpler. It's just the financial return from a single perspective. Okay, so one of the things that we have to think about when we think about ROI is that multiple perspectives may be relevant for value, but when you're talking about ROI, you're doing it from a single perspective. And if you need to incorporate more than one perspective, you either need to find a way to combine them, or you need to either do multiple ones. And some of this is because financial benefits from one perspective can be costs for another, right? If you can reduce utilization, that is great for payers. That's great for patients. That's lower revenue for hospitals, right? So if you're going to come up with what's the ROI? Again, just like with value, you have to say ROI to whom, and you have to pick that perspective. Another challenge, at least in quality improvement, is whenever you introduce a change, one of the criteria for whether or not it's a good change is whether it's sustainable. And if it's sustainable, then it's going to potentially provide benefits for the long term. So in ROI, which is very closely tied to a time frame, we usually talk about return in a year or in 6 months or in 18 months. We have to decide, well, what's the appropriate time frame, knowing that we often have a large cost up front, and we accrue benefits over time as that change sort of gathers benefits, and so adjusting that really can affect our ROI. Challenge 3, ROI is financial benefits, but a lot of times we have to be careful because for a lot of stakeholders, the intangible and non-monetary benefits may be the most important, right? Quality of life, patient experience, things like that, caregiver burden are very important. And it's how we often measure whether care is good and high quality. But those aren't part of ROI unless we can make a direct translation of those to monetary value, which again is why we need to place ROI within a larger context of value overall. And then challenge 4 is more sort of a practical challenge. Care coordination just complicates data collection and calculations. We have data from the home and remote patient monitoring, from the clinic, from the hospital, from the post-acute care, from the community-based organizations, from peer support groups, things like that. If we're really going to assess the value of a change or of an intervention that spans these different care settings, either we got to gather data from all these different places, or we have to sort of acknowledge the limitation that we don't have all this information and either estimate it or just simply say, here's what we don't have, kind of thing. So the way that I've broken down ROI, at least in my book, is just 4 easy steps. There's quite a bit to each of these, but first you define the scope and perspective, which we'll talk about. You identify the cost and benefits. You calculate the base case and the sensitivity, and then the interpretation is key as well. So when I talk about preparing, one of the things that often groups fail to do is consider whether it's even feasible, right? At least when I talk to those who do quality improvement initiatives, a lot of times they'll do the initiative and then say, okay, now let's look retrospectively and say, what was the value? And they go, whoops, we didn't measure anything that has any monetary value, so we can't come up with an ROI. Okay, so before you start, you need to think about things like, are there data that exist that we can actually use to measure value and monetary value? Can we translate it into financial terms? Can we make inferences from those metrics? So it's value is related to quality, but you measure it differently, and you need and one doesn't always equal the other. So in terms of scope and perspective, so the perspective is basically, you have to pick one, right? Of all those ones that were there, you have to pick one. Scope means a lot of things. If we look at a timeline, whether it's an intervention or the introduction of a new device or a process or whatever, if that gray box is the evaluation period, you basically have to figure out where is it appropriate to put that box. How much of the pre-intervention period, ramp up, training, things like that. How much after and during the sustainability period do we want to do? And we need to specify that if we're going to talk about scope. We also need to recognize that we can do ROI analyses prospectively, so before it begins, or we can do it retrospectively after it ends, right? So prospectively, often we're trying to convince a funder that it's a good idea, or estimate the kind of return that a payer or a provider would get if they used our device. Retrospectively, we're probably either justifying what was done, or we're looking for key drivers. What really drove the return? Was it about the effectiveness? Was it about the how many people were recruited? Those different things we can get from sort of a retrospective analysis. So yeah, I'll go through this quickly, but in the falls example, if we choose a payer perspective and say, okay, we're gonna choose a payer perspective, value and ROI is less utilization to treat injuries and lower care intensity, then we need to start thinking about the scope. Okay, who are we going to be doing this for? Is this going to be applicable for all patients? Maybe it's only for high-risk patients, sort of biggest bang for our buck. Is it all levels of care, all areas of facility? So we can't just say, hey, we're going to just introduce this device or this new way of doing things. We need to think about who is it applicable for, over what time period, and what are the sort of parameters around how we're going to do this so that we can be clear about how it's measured. The second step in terms of identifying costs and benefits, often this can be very straightforward, right? It can be, well, we know here's what it takes to implement this new process, or if it's a device, here's what the device costs, right? Sometimes we have to think about things like, is there going to be staff time dedicated to this? Is there going to have to be training? Is there going to have to be new infrastructure or equipment? And we're going to monitor this. So we've added the need for data collection and analysis and presentation and meetings about it. So how are we going to do that? The other thing that can sometimes be difficult is knowing how to monetize the information that we have. So monetizing staff time, monetizing materials, equipment, data collection, sometimes that can be straightforward. It can be harder sometimes to monetize things like patient outcomes, efficiency, quality of life. So there are a variety of ways you can do it. There might be data that you have internally, or that you know about your device or solution that you can use and say, hey, we know that if you reduce falls by this much, it affects your bottom line by the following. Expert opinion, or you may have sort of previous estimates from published literature or previous studies that you've done that you can use. One of the things that I often get asked is, how do we choose the benefits that are relevant for our analysis? There's all these different things that we could potentially measure in the example of the falls. How do we choose what to do? And what I tell groups is you need to choose things that are measurable, monetizable, and attributable to what you're doing. So not everything in that list that you see there is all three of those things. In fact, it might just be fall-related injuries, right? The others might be, some of them might be measurable, some of them might be attributable, but all of them may not be measurable, monetizable, and attributable. And if you're going to do an ROI analysis, you need to make sure that it includes those kinds of measures. One of the exercises that I tell groups to do too, if you're not sure, is create a table where on the left-hand side you write down all the potential benefits of your device or your process or whatever, and then figure out which ones of these are measurable And of those, which ones are monetizable and which ones of those are directly attributable to what we're doing. And you'll almost always find that the list you end up with at the end is a fraction of what you started with. And if you do this beforehand, it can also inform for you kind of the things that you need to make sure you do. Oh, efficiency is the only thing that's all three of these things. We better make sure that we have the appropriate data on efficiency if we want to do an ROI. And so we need to make sure that we have that in place before we even start. In terms of the actual analysis, I often say that an ROI analysis is not complete without a sensitivity analysis. I think whenever we do a base case, we are going to use some level of assumptions or some level of estimates. And if we just put that base case out there, it gives no one a sense of how sure are you of this result. So I tell people it needs to be credible and compelling, right? So the credibility comes in, where is the information coming from? What are the assumptions that you're making? Are they reasonable? But also, how have you explored variability in your scenarios? You can vary the assumptions in the estimates. You can vary the time frame or the other components of scope. You can explore various metrics. So when we talk about metrics, a lot of times we think of just ROI, which is the usual formula: benefits minus cost divided by cost. So basically, that's the same calculation you'd make if you were doing an investment at the bank or something, right? That's the same ROI. There are other metrics that you can use. Benefits to cost ratio is very similar to ROI, but it allows for a more intuitive interpretation that some people like. It's basically for every dollar spent, we get $1.40 in benefits, right? And that can be helpful for some people to sort of internalize what it means. Cost savings per patient, that can put it in terms that, again, are more tangible. The payback period is one I like quite a bit because basically the payback period says, okay, if we were to accrue benefits at the following rate over months, here's how many months until we would expect that we would earn back our initial investment, right? So that's especially useful if you're 6 months into an intervention or a new device, and someone says, what's the ROI? And you say, well, it's negative, right? We've lost money. But our payback period, we expect to be back in the black in another 3.5 months or something like that. These calculations probably not necessarily go through, but just in general, so you can see sort of how they're related. A very simple example: if we have benefits of 35,000, costs of 25,000, the ROI is 40%, and the benefit to cost ratio is 1.4. So they're related, right? They're similar. 40% to some people, they might say, I don't know what that means. The benefit to cost ratio, you can say for every dollar that we spent, we got $1.40 in benefits, and that can be easier to sort of explain. Savings per patient, if you assume there were 34 patients, you can get a dollar value per patient. This can be effective in situations where, say, how much it costs to care for patients on a weekly basis or a monthly basis, and there's some new device or some new intervention, and you were able to save $294 per patient per month. Maybe that's a lot, maybe it's not, right? But putting it in this way is potentially more tangible than just saying we got 40% return. And then payback period, again, you have to assume or have data on, well, we're getting benefits to the tune of $4,500 per month, that we expect our payback period to be 5.5 months, that sort of thing. I'm gonna stop here and just look at the chat here.
Craig, can you help me on you've helped companies come up with these costs. And how do you find them? I mean, I don't think everybody's sharing what their costs are for doing business or for the cost of a fall, or knowing that, an extra day in the hospital costs this much money and therefore you could save this.
Yeah, so that's a good question. And it's actually one of the major struggles, because groups have approached health plans and say, well, tell us what your costs are, and they say, no, we're not going to do that, we'll run it ourselves. So what I do is I rely on published literature. So in a lot of cases, that at least provides a level of credibility to say, there have been this many studies on hospitalizations for heart failure, and on average, the cost of a hospitalization runs between $15,000 and $25,000. I now have my numbers for the sort of high scenario and the low scenario that I'm going to run. Maybe a health plan, your numbers are different, but we don't know what those are. This is the best we can do. And one of the things that I'm a proponent of is being very clear about how you're doing the calculations, what are the pieces of it. So if the health plan wants to take your analysis and simply plug in their number, they can, and they can do it. Now, sometimes there are data available. Because sometimes part of the cost is things like patient activation, for example, is with the home medication adherence. If you can help them, then they feel more empowered. They have more control over their health, and studies have shown that results in fewer utilization, things like that. Well, health plans aren't probably going to have data on what's my members' level of activation. So you may have your own data on studies that you've done with your device or with your solution that you can then insert into there and sort of offer as new. So you're right, you can't usually estimate what others' costs really are, but a lot of times you can get pretty close, or you at least can get in a range that they see it and say, okay, that's reasonable. I see what you did there.
Okay.
You also connect it back with if they needed to go into the emergency, because if they weren't taking their medication, then it could result in an ED visit or higher ED visits, like more frequent, and then there could be like a metric of reduction of that,
yes,
which we know is very costly to hospitals and to that PCP.
Right.
Yeah.
Right, and so the struggle there is when you talk to primary care physicians or ED docs or payers to say, we think that your non-adherent patients are going to the ED with this frequency. We don't know, but based on research, we know that people who have uncontrolled blood pressure, also have diabetes, or also have this, their rate of ED visits are X% higher than these others. Now, maybe your rates are different, but this is what we think. So, and that's, if you get a health plan who comes back and says, nah, it's a little high, or no, that's right on, you can adjust those and go with it. But at least you start the conversation and you come to it knowing what you're talking about, and they see that you didn't just make up numbers, that they're rooted in something, for sure.
So Deborah asked a question about whether or not you needed to do each of these for each of the different stakeholders.
No, I think, and there are other metrics that you can come up with. There's just simply the raw cost savings, benefits minus costs, right? There's a lump sum that you saved. It's really going to be a function of, the perspective and the goal and the motivation and the audience. What are you trying to do? I mean, and the comparison, right? You could say, hey, this device can save you, $10,000 on just 34 patients. Name me another intervention that you can do that's going to save you that much, kind of thing. So maybe they're not interested in ROI, right? Maybe they're interested in the actual raw savings that they're going to see, and they want it in comparison to something else that they've done or something else that they could invest in. Well, why wouldn't I just put that money towards a new MRI machine? Well, here's why, that sort of thing. Mm-hmm. So it really is going to be dictated by the individual situation, and it may, it's really about telling that story. Honestly, it's kind of it's an art and a science sort of together. And if you can combine those so that you have the technical sort of credibility, but you can put it in a compelling story for, hey, look how much we saved, and this is how much it is per patient, or whatever. One client told me, they said, well, this has to speak to both the actuaries and the people in the C-suite. So how do you do that? Right. So you put some of the sort of technical financial ROI calculations in there, but you put some of the other sort of larger tangible things that maybe a C-suite would resonate more with them. Okay, so let's see. Go ahead.
Sorry, just question. Maybe you're getting to this, but how do you do kind of the more qualitative parts of the ROI? So things like, I know the company I work for, we get a lot of feedback from physicians just saying like, thank you, you've made the relationship with our patient better because you scaled us. Like we can focus, like we don't have to do administrative things so much. We can actually like focus on practicing at the top of our license, focusing on the patients that need help. And that's just ends up becoming like there's some quantitative measure in there if they were to time track and like figure out like where they were really spending their time. And there's like efficiency aspects to that, but a lot of it is just like this emotional connection of just like feeling like you are better. Anyways, yeah,
you're exactly right, and that's why you know, I often say in the base case you stick to the measurable, monetizable, and attributable, and then in the sensitivity analyses you can sort of put in some of that larger stuff. You say, hey, we also heard that you're, you know, saving time in this way. If we were to say equate your time to this per hour, that would add this much to the benefits. And you're usually given a little leeway in that sense because you're like, this is your sensitivity analysis. You're saying, let's expand on our base case, right? You're not just throwing everything rosy at them and saying, hey, this is what's true. And it gets them to think about it. And in terms of the interpretation too, this comes back to what I think in terms of putting it in context of the larger value, right? Hey, there's a financial return. It's positive. It's very positive. And on top of that, you have these non-monetary benefits, like the connection that you have with your patients and things like that. I would think that even if your ROI was 0, that would be worth it enough to do it. So again, it's about, what are you convincing them to do, trying to convince them to do? What are you trying to show to them? But it all is part of the story. And that's why I talk about ROI and value together, because I don't think you can necessarily separate them. You can't always monetize everything, but there's still value in it. And so many of the important things are the non-monetary things. So in terms of the sensitivity analysis, again, if we go back to the falls examples, this is just an illustration of what could happen, you know, if you're not careful. So down the middle is our base case. We're going to assume a certain number of facilities. We're going to assume a certain number of patients, a baseline fall rate, how much we can reduce it by, and what our cost of avoidance is, right? If we vary each one of those assumptions just a little, the fact that they build on top of each other, right, and sort of compound, they can result in very different estimated benefits at the bottom. So it's not enough to do a base case. You need to really sort of think about what do I need to think about in terms of the different assumptions. And hopefully what happens is you say, hey, even in the worst case scenario, or in one of the worst case scenarios, you still have a positive ROI. Isn't that great, kind of thing? That's the kind of thing that gives decision makers comfort to say, you know, okay, here's what they think is going to happen, but even if everything falls apart, we're still going to get to this value. When it comes to the interpretation, again, it's not just about the raw numbers. So in this figure, the goal, the point of it is to say, hey, the results on the right have 3 times the ROI that the results on the left do. But the results on the left produce way more benefits, right? So which is better? And it might depend on the situation. You might say, I'm willing to take an ROI of only 10% because look at all those benefits that we were able to accumulate. Yeah, it costs more to get there, but it was worth it. So it's not just about, you know, upping the ROI or getting to a certain level for the metric. It's about the sort of interpretation and how you look at the information. So what can ROI do? It can help you plan and make decisions about future interventions or about your device, right? You can, here's what needs to be true for you to have a positive ROI, or here's how long you're going to have to float the initial investment before you get it paid back, or, you know, here's the better in the decision, here's the better choice to make in terms of which route to fund. Retrospectively, can help you understand drivers of the financial return. What would happen if our effectiveness went up by 10%, how much would that affect the financial return? Or was it about the length of the intervention or the intensity or whatever it is? You can really sort of play with the different values that go into the ROI calculation to say, oh, this was the linchpin. If we don't get, people to do more than X, then we're never going to get a positive ROI, that sort of thing. And then, of course, it can demonstrate benefits. A lot of times it's used to demonstrate benefits with preventive health, technology, process efficiency, anything where you need to make an initial investment in time and resources and money, and then you don't see a benefit, your benefits either delayed or it accrues slowly over time. Those are always difficult decisions for decision makers to make to invest, because they're taking a lot of risk. They're parting with a lot of value up front, and they want to feel comfortable that that value is going to return to them within a reasonable amount of time. But again, I hammer home the necessity to place the results into a larger context. I don't know that it's necessary to go through the examples of the falls. Just the kinds of things you can think about in terms of planning and decision making and demonstrating the value or understanding drivers. I don't know that it's necessary to belabor that at all. When we're talking about interpretation, I sort of have 5 tenets or 5 rules. One is that value is more than the financial return. So don't just talk about the financial return. Value assessments should guide, inform, and teach. If it's obvious, then it's not necessary to do. Okay, there should be something about this that teaches your audience or shows them something that they hadn't thought about or in a different way than they had before. The interpretation needs to combine the technical results with practical considerations, right? How is this actually going to look if it's used on the floor of an ED department? What do we know about this device that means that we're confident that physicians will actually use it and use it at the proper time? Value assessments can also identify what you didn't know. Individual components that are more important than you thought, or areas of opportunity that you didn't realize were as big as they were. So sometimes we're afraid to do value assessments if we don't think the result is going to be positive, but that's not a reason not to do one. You should still do it because you're going to potentially learn something that you didn't know beforehand. And then, like quality monitoring, value assessments shouldn't be a one-time endeavor. Do it over time. Come back to it in 6 months or a year and see how your actual return is doing compared to what you projected. What's changed? What's different than what you assumed would happen? And how is that affecting the return? It should be an ongoing process. Finally, the last thing I want to talk about is actually value-based care. I'm sorry, Elizabeth, did you have a question?
Well, it's just that slide that you just put up with regards to the tenets on there. Value assessments can also identify what you didn't know. There's I can think of a story where there was a proposal to use a different device in an operating room, and until they had spent some time figuring out who are all the people that were going to be affected by this change. In this instance, the biggest change was that there was going to be more time required to clean the operating room between cases. And if they hadn't spent some time figuring that out, they wouldn't have known that actually it reduced their operating room capacity by 7 cases in a day to 4 cases. And that would have been a significant financial return. Now, the cost of goods that were going to be used in doing the surgery were way less, right. but the time on the overall cost were way higher because they was just occupying the room for much longer, and it was not bringing in another case. In this case, 3 other cases, which they would have got a financial benefit on there too. So one case might have been less expensive, but it was a larger impact.
Right. Yeah. I mean, those that's a great example. And there are other ones like that are common. People, it gets back to this, don't just do it when you think you know what the answer is going to be, right? This is something to pursue when you're not sure what the outcome is going to be. So again, last thing, just in value-based care, how does this change. This is particularly of interest for, quality improvement and sort of payer-funded quality improvement, but I think it's applicable across the different sort of spaces. So as payment and reimbursement policies change, assessing value will also change. So very simple situation. In a fee-for-service environment, if you have a payer who says, I'm going to invest in quality, I'm going to pay for an intervention or a device or whatever it might be that results in lower incidence and prevalence, less utilization, shorter length of stay, I, as a payer, am going to see a return in terms of lower reimbursement. And that's relatively straightforward. In a value-based environment or a bundled environment or a capitated environment, however you want to think about it, that same investment in quality, some of the improvements and some of the value from those improvements will stay with providers. Shorter length of stay, fewer adverse events, more efficient care. If they're getting paid by a bundle, by case, by person, if they can provide that care more efficiently, they are going to retain that value themselves. And these are benefits, or these are sort of advancements in care delivery, shorter length of stay, fewer adverse events. What's going to filter back to the payer is going to be smaller than it was before, and it's basically going to be those benefits related to population health, right? Lower incidence and prevalence, lower comorbidity, things like that. So whereas payers previously had financial incentive to improve all aspects of care, including care delivery, they now in a bundled environment are going to be more incentivized to affect population health, while providers are going to be more incentivized to improve care delivery. So it's an interesting sort of, there's not a right or wrong, it's just something we need to keep in mind. The issue, for example, the issue of rehospitalizations and things like that, payers are interested in that, obviously, because it directly affects their bottom line. Providers haven't typically been involved in readmission, and they would argue, hey, there's a lot of things that affect whether or not a patient comes back within 30 days that are outside of our control. Environment, social determinants, their behavior, their choices, all these sort of things. You are asking us to take on population health measures when we are concerned with care delivery. So I don't know what the solution is for that particular case, but these are the kind of conversations I don't hear groups having, payers having, policymakers having, CMS having, and I think we should. I think these are the kinds of things that we need to talk about as we move towards a more value-based environment. So,
do you mind talking, just make sure I understand the differences in what you mean here between population health and care delivery, especially population health, I know is a very broad term.
Yeah, what I mean is sort of, so population health is basically how healthy is the population? How often do they get sick? How often do they need health services? Care delivery is, okay, when they do get sick, how high quality, how efficient is that care? What's the average length of time they need to stay in the hospital? How much redundancy is there within the hospital? How many lab tests do they do unnecessarily? How often do they prescribe a more invasive procedure than they need to, right? And these are all sort of activities in terms of caring for patients. Population health, it could also be thought of like health maintenance, promoting healthier choices and behaviors, taking care of mental and emotional health in addition to physical health, things like that. So
it's almost like out versus inpatient is kind of how I'm hearing a little bit, maybe?
Yeah, or sort of, I mean, the healthiest population wouldn't need any healthcare, yeah. Right? And that would be a payer's dream. They get all the premiums, they don't have to pay anything, right? So they're trying to get as close to that as possible, or at least they're financially incentivized to get as close to that as possible. That scenario would be ruinous for providers and hospitals and physicians, right? And the way that the payment is moving is, instead of saying we're going to pay you for each activity that you do, we're going to pay you this much for a heart failure patient, this much for an AMI patient, regardless of what happens to them, and penalize you if they die within 30 days or come back within 30 days. So providers are like, okay, how do we treat them the best possible during the stay, but save money while we do it? Let's cut out those redundant tests. Let's create a new care pathway that's efficient. Let's, rethink our physical environment so that pathology is closer to radiology, is closer to the OR, that kind of thing. And those are sort of care delivery thought process. Does that make sense? Okay. So that's it. You always are free to reach out to me directly. I know that Elizabeth said she's going to put the link to the book in the chat or send it out. A teaser. There's a follow-up coming. I have to get it to the publisher here in the next few weeks. It's on value more generally, as opposed to just ROI, assessing value sort of in the larger sense, and that should be out late first quarter, early second quarter of next year.
So we have a couple of questions for you,
Sure.
Craig. If you want to stop sharing your screen so we can see everybody a little bit more,
Sure.
and you. Here's the one of the questions is how does this process of value documenting align with the impact metrics accounting that the Sustainable Accounting Standards Board and John's put a link on there. You may or may not be familiar with that.
I'm not.
But we'll save the chat for you so that
Okay.
yeah, you
Okay.
can have that as an up.
Yep.
John, do you have some more?
So we have this messy question when we talk about impact investing of what do we mean by impact and who is impacting what, and it has a lot of relationships to the conversation you were trying to outline of what's measurable and what is financial and what is an impact and who gets the benefit of the impact. And there have been a bunch of accountants who have put their head down for the last decade trying to figure out how to make that happen. So if you think about the equivalent of a B Corp and running through all the checklists for a B Corp, there's some of those checklist items that are meaningful on return on investment, which may or may not be accountable or possible to go. But as I have an entity and I claim an impact, then I should have a mechanism in my business modeling to measure my impact and then track my achievement of my goals, right? And they're trying to create the framework to do that. And so maybe that's a framework that you can steal from or otherwise.
I think that, I think, and actually this is a lot of what I go into in the book I'm writing right now. I think that at a minimum that a framework is necessary, right? Because I think, on the federal level, CMS doesn't have, for example, a way to compare the value of this initiative with the value of this initiative, right? And that's almost criminal, right? How do you not have something in place to say, this one is worth more than this one, or we got a better return from this one that we got from this one? And it's really a function of the fact that there is no framework. There's no common way of saying you need to have these elements in place if you're going to talk about value and if you're going to link reimbursement to value. It has to at least have this and this and this and this and this. So I will look at those and for sure steal what I can. Thank you.
There are some folks in Seattle who have been active in the development of this, so
okay.
We can go hunt them down if you need to.
Okay, thank you very much.
Deborah, you want to ask your question about seeing a shift to value-based?
Did you see self-payers like Boeing? I know they self-pay their insurance. Did you see a shift in their approaches in reimbursement?
Well, value-based care is being adopted across the board. So public, private, everything. Because again, for payers, it makes sense, right? They are financially incentivized under those systems to promote population health, right? Let's offer services that are going to help people be healthier and have better well-being and things like that. The groups that sometimes get left behind are the providers, right? Yeah. Because they say, wait, you can't pay me the same for these people as these people because these people are different, right? And so we haven't really sorted out exactly how that is. I mean, for example, a good example is a lot of the mid-market insurers, so not the huge insurers, but the ones that, are smaller ones and self-employed or self-insured groups. Once we got 6 or 8 months into COVID, really started to realize, hey, we need to offer emotional and mental health benefits. Mm-hmm. It's worth it. Like when we do that, like it's needed. You started seeing that some of them started offering covering like the financial planning and you know, different sort of life well-being components outside of you know, physical health. So in some ways, I think that the self-insured, you know, self-insured corporations and the mid-market insurance companies are really where we will make the fastest move towards some of these gains that we see. You know, the federal government, it moves too slow. And some of the large payers, you know, the problems that the large payers see, those problems need to be big enough before they actually take a look at it. So it's really I think the mid-markets that are the most innovative when it comes to sort of how best to employ some of this value-based care.
And just a follow-up, are you seeing, you know, Medicare is complicated because they do so much through supplementals or Advantage and all that. Are you seeing Medicare moving to value-based?
Medicare has been, they're the ones who sort of started this push. So back when, you know, the ACA and MACRA.
SCA did it, yeah.
Well, the ACA and specifically MACRA, so the Medicare something and CHIP Reauthorization Act had a clause in there that mandated that at least some of payment reimbursement would be linked to quality measurement within X number of years.
Okay, I was going to ask you what the forcing function was, because it seems to have picked up. The momentum has picked up. So it was that. Yeah,
it was it was federal, you know, legislation that required it, and it was on this increasing scale. By this many years, it's got to be at least 2%. By this, it's got to be 4%. Things like that. And again, for Medicare, they make sense for them. It helps them potentially keep costs down, and for them, it's a zero-sum game. So basically, they penalize some hospitals and they reward others, but the way that they do it is they take the money from those hospitals and give them to those money. So Medicare, you know, it's not like they're shelling out extra cash.
Mhm.
It's all relative. And then there's a whole can of worms, because physicians are monitored, hospitals are monitored. Physicians can be monitored on the same condition and a similar quality measure by two different programs and have two different levels of performance and have two different levels of penalties or bonuses, just because they do them differently, like they analyze them differently. And they're not very transparent about how it works. So they've actually made it more complicated than it has. And the other wrinkle is the percentage of patients who are in, percentage of Medicare patients who are in Medicare Advantage, so capitated care, has almost doubled, right? It's now a lot of times, in a lot of states, 40%. Whereas 10 years ago, it was 20%. So pretty soon we're going to get to a point where, you know, half of them are in Medicare Advantage anyway, right? Which is a capitated program. So these quality improvement or these quality measuring value-based purchasing programs in Medicare are all fee-for-service. Like they're trying to move fee-for-service to value-based. But patients are moving to value-based on their own because they're just moving to Medicare Advantage. Now, there's all sorts of disparities in race and gender, race and socioeconomic status and things like that about who joins Medicare Advantage, but that's a different thing.
Thank you.
Yep.
Rachel, you asked a question, which I'm not sure if it was a Freudian slip here, but you said, can you talk about payviders? I think
That's
you
right.
possibly meant providers, what they care about in the VBC world. And if it's actually providers, Craig might have just answered that question, but.
I was told that there's actually like a real thing called payviders, which is like a more emerging segment.
Oh,
within the
terrific.
healthcare world.
It's not, it's
Yeah.
new to me. So Craig,
Yeah.
have you heard about that?
That's new to me too. Tell me about payviders.
I don't know. I thought it was like, so that's what I wanted you to tell me
I
about.
haven't heard
Is
the
that,
term.
like,
I haven't heard the term payviders before, but like Roof Health was both an insurance company and a provider, or they.
that's exactly
that,
it. Is
yeah.
that that's all I know. about
They
them.
provide
And to
and
me,
pay.
Oh,
There's,
sure.
there's several big companies that do that.
Yeah.
Sure. Okay. Yes.
Yeah. And so, because we were talking about it in a very specific way of like, if you're a provider or you're a payer or, you know, like and kind of who the perspective is coming from. So I was just trying to imagine, oh, like what if you have a combined perspective? And then I thought of a payvider, which the only thing I knew was exactly what Deborah said.
Yeah, I mean, I think in that
Yeah.
situation, you know, they wouldn't necessarily have any formal structure over it. They would just say, how can we provide the care we need and do it as cheaply as possible? And they wouldn't need to institute any rules because they're all sort of the same entity, I think. But I think the idea is the same, right? And I think the reason that groups move to that is for that reason. They have the control over it because they don't like, you know, the current system and the inefficiencies in it. Because I mean, the other part of this is as soon as you introduce, you know, value-based care that requires you monitor all this quality and stuff like that, the administrative burden just went through the roof, right? Because now you have to collect all these measures. Now you have to document everything. Now a whole division of CMS has to crunch these numbers and figure out who gets paid what. And, you know, I'm sure that the cost of doing that far exceeds any savings that they might see in terms of, you know, reduced utilization.
I'm just putting a couple of links in there. One's a definition right off the internet, so you can't believe it all. But the second is Becker's actually got it's a Becker's Hospital Review has an article that's been out for a couple of years. So this has not been a new topic. A capitalized contract. John, do you want to ask that question?
Wasn't a question, just a definition. I hadn't, it was, Craig was using the word capitated program and I didn't know what it meant. So maybe someone else didn't know too. So,
yeah, I mean, maybe I don't use it appropriately, but I think of it as basically, you know, a shared risk model. So the provider gets paid a fixed amount for this type of patient. It's capitated.
I think of it as Kaiser versus Blue Cross, right?
Okay.
Kaiser is fixed fee per person. Doesn't matter how sick they are, and Blue Cross is all twiddly with all of their numbers, all of it does.
Yep. But the capitated is more in line with sort of the bundled payment. I mean, the bundled payment is sort of how CMS thinks of it. They're like, hey, for hip replacements, this is what you get. And, you know, we normally, instead of billing for the surgery and for the antibiotics and for the rehab, we're going to bundle it all together and you get this amount and you figure out how to pay for it. That's basically the same thing. Other questions or thoughts?
Now, if you're a company, so we've got founders on here, how are you going to take this information and go back to your investment pitch and incorporate some of the content?
Well, in our case, we started with this. We looked at the problem and created a solution. We didn't start with our solution. In healthcare, I wanted to say earlier, but I didn't want to monopolize conversation. What happened in the ACA is they started penalizing hospitals for their second hospitalization. They just don't get paid. Right. So there's a lot of incentive. And I was going to offline contact you about your little arrow charts, because the heart failure does have that forcing function on providers that they don't get paid. So in that case, they are incentivized to change their behavior.
Yep.
Because they're eating a second hospitalization or third, depending on.
Right, and the argument really comes in with how much of the reason for that second hospitalization is because of the care of the first one, and how much of it is because of what happens afterwards. Their support system when they go home, their adherence to therapy, their behaviors and their diet and their exercise and their follow-up appointments and things like that. That might be out of the purview of the hospital. Yeah. And that's
well, to your point, it's really well documented in the scientific literature, and there's, you know, they've been doing this now for about 10 years. So there's documents on how hospitals are moving them to nursing homes early, and there's quite a bit of information. The actual, is it fair to say you can present this as quite a controversial topic, to your point? You know, how much do the doctors have control over it?
Yeah, and more recently too, some researchers have started to use the phrase potentially avoidable rehospitalizations, right? Because there are ones that aren't avoidable, and there are even ones that are planned, right? And in the early days of this, it was any hospitalization. Well, they had planned to go in. They had an elective thing scheduled, and it just happened to be 23 days after their unplanned, stay there, and they got dinged for it, kind of thing.
Yeah, but yeah, we're all aligned here, but they still don't get paid for the second one. And they've not made, it doesn't appear they've made much movement on getting that undone.
Yeah, I mean, yeah, it's complicated.
It's complicated.
Yeah.
I agree.
Another question.
Go ahead there,
Well,
Rachel.
just quickly. I think what I'm trying to take away from what you're saying, so are you saying that providers don't necessarily want to go to a value-based care?
No, I don't. I'm not trying to say that. I think my own opinions are coming across too strongly. I think I think there are providers who welcome it in certain situations, right? I think there are ones who say, we know how best to care for our patients. Just tell us what you're going to pay us and we'll figure it out. I think the difficulty is in the details and in the implementation of it. So who counts as a heart failure patient, and where does that diagnosis code need to land on the claim? How far down the list before they do it? And what if they develop an infection in the hospital that has nothing to do with what we did, or what, you know what I mean? So I think that they're open to the idea of it, and when it's done correctly, I think providers often feel like decisions are made about how it's done without them, and they would say, hey, this doesn't, there's all sorts of articles by physicians who say, this doesn't make sense for this type of patient, and here's why, and it wasn't really considered. And so I think that we just need to come to the common ground where physicians and also hospital administrators and those in charge of sort of running these facilities agree with policymakers about, here's what's fair, here's how we identify them, here are the contingencies, so that every possible scenario is accounted for, which can never happen, right? You're never going to account for every possible scenario. So it is, as John said, it is a devil in the details kind of problem for the hospitals.
Well, this is a complex topic, and we, in terms of as an investor, we're wearing a couple hats here. We've got as a company making these pitches, as an investor trying to evaluate whether or not, in the long run, the hospital is actually, or the payer system is going to pay for the initiatives that are being proposed, right? And therefore, there'll be a return on the investment, not necessarily from the provider, but more of a financial return. And then we've got, what does this impact in terms of making changes and incorporating some of these philosophies when you do product design, like Harold teaches medical product design. And, some of the aspects of thinking about these kinds of things are important when you're actually doing the design components. How, by putting certain things together, are they more likely to be successful in terms of a reimbursement strategy also, the bundling. Well, I think we look like we might be coming to the end of our questions here, Craig, and we know that you are actually on Eastern time, so
Central, but yes.
Central, but you're an earlier time frame for us. Harold is in Toronto, and so I think what we'll do is we'll give you guys back a little bit of time this evening. We hope that you've enjoyed the discussion, everybody.